Third lecture of cell injury 3. After we talked about causes of cell injury, mechanisms of cell injury, now we are going to shift to the morphological changes. Look at this. This is an injured boy, so we talk about the morphology, the shape. Okay. By the end of this lecture, you should be able to describe the morphological changes of reversible cell injury, describe the morphological changes of irreversible cell injury, define necrosis and list its types, explain the causes of the morphological changes in different types of necrosis, and then describe the morphological changes and list examples of different types of necrosis. At first, think. If a cell is exposed to injury, which changes will occur at first? What do you think? Functional changes or structural changes? If we look at this diagram, here we can see myocardial cells exposed to ischemia. Okay, they will be non-contractile within 1 to 2 minutes after ischemia. So they are going to lose the function, okay, 1 to 2 minutes after ischemia, die after 20 to 30 minutes. Fine? So it starts by ischemia, and in this first half with reversible cell injury, okay, you have diminished cell function and within 2 minutes, and then after 20 minutes of complete ischemia, I'm going to pass into cell death, irreversible cell injury. This irreversible cell injury will start by changes in the ultrastructure, and then by the light microscope after about 6 to 12 hours, and then gross morphological changes by 12 hours. So I'm not going to see part of the wall of the heart by my naked eye dead, except after 12 hours of ischemia. This means that these morphological changes take some time to appear here, while the function is already lost from the first 2 minutes. So the electron microscopy changes will be by 2 to 3 hours at the level of the cell, okay, at the level of the organelles, at the level of the nucleus, and then light microscopic changes will occur by 6 to 12 hours. When you take a section and you see the tissue, you are going to find changes in the tissue by the microscope, and then gross changes by 12 hours. You need 12 hours so that you can see by your naked eye part of the wall of the heart dead. So this means that functional changes occur at first, or they appear at first before morphological changes. The morphology of cell and tissue injury. At first, the effect is at the molecular and biochemical level, leading to loss of cellular function long before cell death occurs. يعني البايوكيميكال changes هتحصل الأول، وهيبقى الفانكشن disturbed قبل ما يبان الشكل بتاع السيل death. The cellular derangements of reversible cell injury can be repaired. واحنا عشان كده قلنا هو reversible يعني بيرجع تاني. If the injurious stimulus abates, the cell will return to normalcy. If I stop the stimulus, so I'm going to return to the normal status, and this is the meaning of reversible. But persistent or excessive injury, however, causes cells to pass to the nebulous point of no return, طريقة أو نقطة اللا عودة, into irreversible cell injury and cell death. Whenever cell death occurs, it doesn't go back to normal. Reversible injury. We have two patterns of morphologic changes can be recognized under the light microscope in reversible injury. Cloudy swelling or hydropic change and fatty change in some organs. So reversible injury هنا الخلية بتحوش حاجة من اتنين، يتحوش مية water، يتحوش fat. Okay, so the cell accumulates water or fat in reversible injury. If it accumulates water, this is called cloudy swelling or hydropic change. If it accumulates fat, this is called fatty change. Fine. These two forms are reversible cell injury and can go back to normal if I remove the injurious stimulus. Starting with cloudy swelling or hydropic change or vacuolar degeneration. All these are synonyms. كل دي أسامي لنفس الكونديشن، يعني كل الأسامي دي متساوية. Cloudy swelling equals hydropic change equals vacuolar degeneration. The first manifestation of almost all forms of cell injury. So it occurs at first. يبقى ده بيبان في كل أنواع الcell injury في الأول خالص. It occurs in highly specialized organ. Remember when I told you that if I lose the electricity for 3 hours, the highly specialized organs will suffer more. And so the reversible cell injury occurs more in highly specialized organs because they need energy all the time. And if I have even transient ischemia or transient ATP loss, I'm going to have suffering in these highly specialized organs. They mean, for example, you have the liver, you have the kidney, these organs, you have the heart, these organs that are highly specialized, and so they can suffer early from this reversible type of injury. The hydropic swelling or cloudy swelling results from failure to maintain the ionic and fluid homeostasis. Why? Due to failure of sodium pump. So sodium pump failure will lead to failure to maintain ionic and fluid homeostasis with influx of sodium and water and cell swelling. The gross appearance, if you have a lot of water inside the organ, so the organ will have increase in weight and it will be more pallor. Microscopically, what do we have? Remember, if we have sodium pump failure, so I have sodium going inside with water, and so there will be swelling of the total cell like that, and at the same time I have swelling of the organelles because the organelles just take also sodium and water, and so they become swollen. If you have swelling of the endoplasmic reticulum, so the endoplasmic reticulum will change into small vacuoles. Look at this picture. This is a liver cell and this is another liver cell. All these are liver cells. This is the cell membrane and it is intact, fine, it's okay. Look at the cytoplasm. The cytoplasm is pale, and if you look closely you have some vacuoles here. You have a vacuole. Look at another one. This is another cell. Look here, you have the cell membrane intact, the nucleus is fine, you can find the nucleolus, so the nucleus is living. Look at the cytoplasm, it is pale, and you have two vacuoles, one vacuole and another vacuole here. Here again another cell, you can find this vacuole, okay, and here you can find vacuoles inside the cell. What are these vacuoles? These vacuoles represent dilated endoplasmic reticulum, okay, and this dilated endoplasmic reticulum contains a lot of water, and so they become round and look like vacuoles. So they call this lesion vacuolar degeneration because we have small clear vacuoles in the cytoplasm. Fine. Cellular swelling in hepatocytes. This is a kind of alcoholic liver disease. Patients taking a lot of alcohols for alcoholic beverages for a long time. So he will have some injury to hepatocytes, and this starts by hydropic swelling or vacuolar degeneration. Look at this. Do we have dead cells or living cells? If you have intact cell membrane and you have intact nuclei, so you have a living cell. But this cell has just these vacuoles and clearing in the cytoplasm. Fine, so this means that we have viable cells. They are not dead, they are living cells, and they suffer from reversible injury. If you remove the stimulus, all this water will go out and the cell goes back to normal. Compare and mention the differences. Here we have a diagram showing a normal cell, ultrastructure, and here we have a cell with reversible injury, also by ultrastructure. This diagram shows the cell containing the nucleus, cell membrane, and the organelles. If you look at this is the normal cell. You can find intact cell membrane, and it is totally intact with no plebs or no indentations. You can find inside an intact nucleus with nuclear details with nucleolus. You can find mitochondria, they are fine. you can find intact lysosomes, and you can find intact endoplasmic reticulum with all these ribosomes attached to it. If you look at this figure in reversible cell injury, start with the cell membrane. The cell membrane, fine, it's intact, it is not disrupted, but it shows some plebs. So we have plebs here in the cell membrane. Look here, you can find some, look at the endoplasmic reticulum and compare it with this one. It is just swollen, and you can find dispersed ribosomes. So there is detachment of ribosomes from these dilated endoplasmic reticulum sacs. You can find the lysosomes are intact with no rupture of their membranes. You can find mitochondria are swollen, and some mitochondria are here being eaten by some lysosomes. This is called autophagy, and this autophagy occurs to eat old mitochondria and old organelles, trying to save some energy. Look, this is the nucleus. It has a good nuclear membrane. It has nucleolus, but you have this some clumping of the chromatin. You have clumps of the chromatin here, but still you have the nuclear details apparent. So you have just chromatin clumping. Remember, we have these plebs, and these plebs result from swelling of the cell. We have generalized swelling of the cell. We have clumping of nuclear chromatin, and if you go back to the lecture of biochemical changes, remember that decreased pH of the cell results in clumping of nuclear chromatin that occurs due to ATP depletion. Fine. Autophagy by lysosomes to all the organelles, trying to save some energy. We have endoplasmic reticulum swelling with dispersion of ribosomes, detachment of ribosomes, mitochondrial swelling with small black densities inside. Fine. This is the reversible kind of injury. Sometimes with autophagy like that, we have some destruction of the membranes, and we can have few myelin figures. Remember these myelin figures. Phospholipid masses. So the morphology of reversible cell injury. The ultrastructural changes of reversible cell injury that we have seen in the diagram are written here. The plasma membrane alterations show blebbing, blunting, or distortion of microvilli due to this marked swelling. If I have some microvilli, so I'm going to lose the microvilli. Loosening of intercellular attachment. If I have these cells together, they are attached by desmosomes. I have widening of this space and loosening of cellular attachment, and I may have few myelin figures inside the cell due to some destruction of the small organelles. Mitochondrial changes include swelling and appearance of small phospholipid-rich amorphous densities. These densities present inside the mitochondria, the black densities. Dilatation of endoplasmic reticulum with detachment of ribosomes. Okay, the ribosomes become detached like that. Okay. Nuclear alteration shows what? Shows clumping of chromatin. You have the nucleolus, and you have just clumping of the chromatin, few clumps of chromatin here, but still you have the details of the nucleus. This is not pycnosis. So this is just clumping of chromatin, and this is due to decreased pH of the cytoplasm. If you look at this diagram is a cell with irreversible type of injury, and again it is ultrastructure. Look at it and try to identify the morphological changes that occurred in this cell. Start with the plasma membrane, the cell membrane. Can you see that the cell membrane is not a continuous line? It is interrupted line. So we have disruption of the cell membrane. This is important. You can see that this cell is still swollen. Okay, the cell is large and swollen, so we have swollen cell with disruption of the basement of the plasma membrane, and you can find these myelin figures. They are a lot. You can find them beside this disrupted membrane, and you can find them beside disrupted or digested organelles. If you look at the endoplasmic reticulum, it's swollen, yes. It has dispersed ribosomes, yes, but look at the membrane surrounding the endoplasmic reticulum. You can find that it is also disrupted or interrupted, so you have interruption or destruction of the membrane surrounding the endoplasmic reticulum, and this will lead to formation of myelin figures beside these disrupted membranes. You can see that the lysosomes have also rupture of their membranes and release of their enzymes to start the digestion of the content of the cell. Look at the mitochondria, swollen mitochondria, and you can find that the densities here are larger than in case of reversible injury. You have larger densities containing calcium, and this will lead to calcification later on. So we have large densities inside the mitochondria. Look at this nucleus. This nucleus is different from the reversible injury. You don't see, it is small, condensed, and you don't see any details. It is just dark like that. This is a pycnotic nucleus. So this nucleus shows the nuclear changes of cell death, which is pycnosis. We can find later on fragmentation, which is karyorrhexis, and even total absence of the nucleus. So the changes here include what? They include rupture of lysosomes and autolysis. Okay, they include nuclear changes in the form of pycnosis, karyolysis, or karyorrhexis. You can notice a lot of myelin figures, frequent myelin figures. Okay, not only one myelin figure, they are frequent. You have lysis of endoplasmic reticulum with loss of the membrane surrounding it. We have defects in the cell membrane, they can see them. You have large densities in the swollen mitochondria. All these are ultrastructure changes of irreversible injury. What are the two most important features here? The rupture or interruption of the cell membrane and organelle membrane, and the nuclear changes, which are pycnosis, karyolysis, or karyorrhexis. All these mean that this cell is dead and it cannot go back to normal. This is a kind of irreversible injury. So the ultrastructure changes of irreversible cell injury include cell membrane defects, mitochondrial swelling with accumulation of calcium-rich densities, lysosomal rupture, frequent myelin figures, nuclear changes in the form of pycnosis, karyorrhexis, and karyolysis. Match this question. Reversible injury, irreversible injury, and adaptation. Okay. Pycnosis goes where? Pycnosis goes where? Goes with irreversible injury. Yes. Swollen endoplasmic reticulum, just the swelling of the endoplasmic reticulum goes where? With irreversible injury. Increase in cell number. Increase in cell number. This is hyperplasia. This is adaptation. Very good. Cell membrane defects. Cell membrane defects goes where? Of course, it goes with irreversible type of injury. Chromatin clumping, just clumping of chromatin, goes where? Again, it goes with reversible injury. Okay, you can just have clumping of chromatin and you see the details of the nucleus. This is a reversible injury. Okay, frequent myelin figures go where? Frequent, when they're frequent, so they denote we have irreversible membrane damage. And then we have frequent myelin figures. As we have said, it is always related to irreversible type of injury if they are frequent. Okay. آخر حاجة change of cell type, and change of cell type means what? Metaplasia. Very good. And metaplasia goes with adaptation. تمام. يبقى ده الماتش question بتاعنا. Types of irreversible cell injury. يا ترى ايه انواع irreversible cell injury؟ احنا قلنا السيل death عندنا نوعين، يا اما necrosis يا اما apoptosis. We have two types of cell death which differ in their morphology, mechanisms, and roles in disease. They are necrosis or homicide, apoptosis or cell suicide. Necrosis occurs when damage to the membranes is severe. If I have severe damage to the membrane, so I'm going to have cell necrosis. With damage of the membrane, severe damage, I have leakage of enzymes out of lysosomes and leakage of contents out of the cell. So I'm having this damage of the cell membrane leading to leakage of metabolites or contents outside the dying cell, and at the same time I have leakage of lysosomal enzymes outside these ruptured lysosomes. The leakage of lysosomal enzymes will lead to digestion of the contents of the cell, which culminates into necrosis, and the leakage of cellular contents outside will elicit host reaction, which is inflammation. If I'm having this leakage outside, so the immune system will understand this signal and starts to send the inflammatory cells to the area of necrosis, and this will elicit the host reaction or the inflammation surrounding the area of necrosis. So the damage of the membranes is severe. This leads to leakage of contents outside the cell, elicit immune reaction or a host reaction in the form of inflammation surrounding the necrotic area, and leakage of the lysosomal enzymes outside, leading to digestion of the cellular contents, giving the morphology or the picture of necrosis. What is the definition of necrosis? It refers to death of group of cells within the living body. So you need to be living, okay, we have a living body, and group of cells die during life, okay. This is different from post-mortem. ده مختلف عن الموت. لو الواحد كله مات ما بنسميهوش necrosis. النكروزس بيطلق بس على death of group of cells جوه البني آدم اللي عايش within the living body. Death of group of cells within the living body. Followed by الحاجتين اللي احنا قلنا عليهم. Degradation by hydrolytic enzymes released from lysosomes and accompanied by inflammatory reaction due to leakage of cellular contents outside the ruptured cell membrane. So the necrosis refers to death of groups of cells, مجموعة من cells within the living body, and this is followed by degradation of the contents of these cells and inflammatory reaction, okay, surrounding the area of necrosis, accompanied by inflammatory reaction. The morphologic appearance of necrosis is the result of essentially concurrent processes. We have two processes giving the morphology or the predominant morphology of the necrotic area. And so, which is more predominant in the dead cell? Is it enzymatic digestion or protein denaturation? What is protein denaturation? Protein denaturation means that the proteins present in the cytoplasm and including the enzymes are hard, denatured, coagulated and hard. So the protein in the cytoplasm will be hard and coagulated or denatured, and this occurs due to the effect of acidity. So the marked and rapid decrease in pH of the cytoplasm due to lactic acid release from anaerobic glycolysis leads to denaturation of the proteins or coagulation of the proteins including the enzymes, leading to hardening of the cell. So the cell becomes hard like that. Or we have the predominant enzymatic digestion, in which the hydrolytic enzymes released from the lysosomes take the upper hand and start to digest the cell, and so the cell become digested and liquid-like. So in this protein denaturation, the cell becomes solid. In enzymatic digestion, the cell becomes liquefied in a liquefied state. So the morphologic appearance of necrosis, is it solid, is it liquefied, or whatever, results from the two processes, enzymatic digestion and protein denaturation. Which takes the upper hand, okay, will give a certain morphology. We have 5 types of necrosis and gangrene. The types of necrosis include coagulative type of necrosis, and remember the boiled eggs. Liquefactive type of necrosis, and remember the juice, it is liquefied like a juice. Caseous necrosis, that looks like cheese. Caseous necrosis, the necrotic area looks like this cheese, so it is called caseous. Then we have fibrinoid necrosis, fat necrosis. These are the 5 types. And lastly, we have gangrene, which means necrosis followed by putrefaction. In some textbooks, they call it gangrenous necrosis, and in other books, they call it just gangrene. Coagulative necrosis. What is coagulative necrosis? It is the common form in hypoxic injury of cells in all solid organs except the brain. What are these solid organs? Heart, spleen, kidney. These are the infarctions occurring in heart, spleen, and kidney are examples of coagulative necrosis. What is meant by infarction? Infarctions means necrosis due to ischemia. يعني a necrosis that develops due to cut of blood supply. So I have necrosis of part of the wall of the organ. This is called infarction. So ischemic necrosis is called infarction, and this can occur in different organs in the body, including myocardial, splenic, kidney, lung, okay? And even the brain can have infarction, but actually the brain doesn't have coagulative necrosis. What is coagulative necrosis? Coagulative necrosis means that the necrotic area is solidified, okay? If you look at this picture, if you have an egg, لو عندنا بيضة بيضة نية, you have a raw egg, بيبقى فيها ايه؟ بيبقى فيها الصفار وفيها البياض سائل. You have the white of the egg is liquid and it is transparent, and you have the yellow part of the egg, yellow of the egg. If this egg is broken, you are going to have the white of the egg liquefied like that, and you have the yellow part of the egg like that. So if it is broken, لو أنا كسرت البيضة وهي نية, هينزل البياض في صورة ايه؟ transparent fluid, okay, and you have the yellow of the egg. Fine. ده لو هي نية. طيب if I boil the egg, حطيتها على النار وسلقتها, يحصل ايه؟ بتيجي بعد كده اجي اقشرها. if I break the shell, I'm going to have what? I'm going to have a egg, a hard egg, solid, okay, white egg. So I'm going to have a solid and white egg, وفي نفس الوقت it will take the shape of the shell. Okay, what happened to the egg if it is boiled? It have protein denaturation occurs, protein denaturation or coagulation of the protein اللي موجود في البياض ده. I'm going to have protein coagulation or denaturation, and this changes the physical properties of the protein. So it becomes, from the liquid state, it becomes solid, and from the transparent appearance to white appearance. So it becomes solid and white, and at the same time it takes the shape of the shell. It was inside the shell, so it takes the shape of the shell. So if I just remove the shell, it will be still ovoid like that of the previous shell. Fine. This occurs due to coagulation of proteins of the white of the egg with the transformation into solid white tissue with taking the shape of the shell. Okay. In necrosis, what is the relation between this and necrosis? In coagulative type of necrosis, I have denaturation of protein of the cell occurring due to acid. It is not due to boiling this time, but it is due to acid. يعني بيحصل denaturation للبروتينز اللي موجودة جوه الخلية، بس المرة دي مش بسبب البويلنج زي ما حصل مع البيضة، المرة دي هيبقى بسبب ايه؟ الاسيد. ايه الاسيد ده؟ جه منين؟ اللي هو اللاكتيك اسيد. فاكرين اللاكتيك اسيد؟ Do you remember lactic acid? Lactic acid comes from where? Lactic acid comes from anaerobic glycolysis occurring inside the cell due to ATP depletion. So this anaerobic glycolysis, if it is extensive due to severe ischemia, so I'm going to have increased amount of lactic acid with rapid and sharp decrease in pH. This will lead to denaturation or coagulation of the proteins present inside the cell. cytoplasm, and even the enzymes, denaturation of both proteins in cytoplasm and denaturation of enzymes released from the lysosomes. If the enzymes are denatured, so they are inactive, they cannot work, they are solidified and denatured, so they are not active. And so this leads to what? This leads to solidification of the cell. The cell becomes solidified like the boiled egg, with taking the shape or the appearance that it was put in, and it becomes solidified. The cytoplasm becomes more eosinophilic. Why? Because the denatured protein takes more eosin, so it becomes more eosinophilic, and at the same time I'm losing what? I'm losing the endoplasmic reticulum, losing ribosomes, losing the nuclei by karyorrhexis or by karyolysis. So I'm losing part of the eosinophilia of the cell. So I have increase in the eosinophilia, I'm losing part of the basophilia of the cell, and so the eosinophilia increases more on the expense of the basophilia. So in coagulative necrosis, the necrotic cells take the shape of the previous structure that they were forming, and they become more eosinophilic. The nuclei are lost, or they have disappeared, or karyorrhexis or pycnosis, fine. And these necrotic cells will give a solidified appearance in the gross picture. Of course, we remember that the membrane is disrupted of each cell, but the outer outline, that this was a gland, for example, or a tubule in the kidney, the outline is like the egg of the shell. You still have the outlines preserved, or structural outlines preserved. You can say that this was a tubule, but the lining cells become ghosts of cells with intense eosinophilic cytoplasm like that, and nuclear changes of necrosis, pycnosis, karyorrhexis, or karyolysis. Okay. At the same time, these necrotic cells will be surrounded by inflammatory cells, neutrophils and macrophages. They will come, this is the host reaction, they come from dilated blood vessels surrounding the necrotic area and come trying to eat or clear the necrotic tissue, as you are going to learn later on in inflammation. Okay, so the surrounding tissue will show inflammatory cell infiltration. Fine. So this is the process of coagulative necrosis. We are going to erase these things so that we can read. Fine. So, in coagulative necrosis, we have said that it is common in hypoxic injury of the cells in all solid organs except the brain, occurring in myocardial infarction, splenic infarction, kidney infarction, lung infarction. Okay, and infarction is ischemic necrosis, as we have said. Predominant here is protein denaturation or enzymatic digestion. No, here we have predominant protein denaturation. Why? Because there is marked and sharp decrease in pH, which leads to denaturation of the structural proteins and enzyme proteins, leading to blocking of the cellular proteolysis in early stages. So the proteolysis, which means the digestion of the contents of the cell, is blocked in the early event of the necrosis. We have preservation of the basic structural outline of the affected cells. We have the structural outline of the gland or of the acinus or of the tubule is maintained. We have increased eosinophilia. Why? Because we have increased binding of the cytoplasm to the denatured to the eosin, and we have also nuclear changes, which we have pycnosis, karyorrhexis, karyolysis, and this will add more to the eosinophilia, as we have said. If we look at gross and microscopic picture of renal infarction as an example of coagulative necrosis, look at this. This is a part of the kidney, okay? And this is the capsule of the kidney from outside. This is the capsule, and this is the hilum of the kidney. Fine? If you go and remember the blood supply going inside the kidney, you have an artery that branches like that. Fine, and you have branching of each artery, and each branch will supply a triangular area starting the apex towards the hilum, and the base is on the capsule of the kidney. So we are going to divide the kidney tissue into triangular areas like that. Each one is supplied by one of the arterial branches. If I have occlusion of one of these branches, I have ischemia of a triangular area like that. So I'm going to have ischemia of a triangular area due to obstruction of one arterial branch. And here we can see this part, which is the triangular part here. Look at this triangular part. This triangular part has its apex towards the hilum and base near the capsule, but the capsule is not involved because it has a different blood supply. So this triangular area is just beneath the capsule. This triangular area, if you can see, it is yellowish white in color. Okay, this is the color of the kidney. It is dark in color due to a lot of blood inside the kidney. But look at this area, that area is pale in color, and it is firm. Okay, firm in consistency. So we have pale firm area that is triangular in shape, and it has the apex towards the hilum and the base towards the capsule. Okay, later on it becomes opaque and becomes softer when inflammation occurs. So at first it is pale, firm and swollen like that and triangular in shape. Later on it will become softer and more yellow due to inflammatory component. Of course, you have the surrounding area here, surrounding zone shows darker red color. Why? Due to you have dilated blood vessels that will bring the inflammatory cells surrounding the area of infarction. You have zone of hyperemia or congestion surrounding the area of infarction, so they can just bring the inflammatory cells to the area of infarction. You are going to learn this in details in inflammation. Okay, at the microscopic level, what can we see in the microscopic level? If we take a section like that, look at this rectangle. This rectangle shows you the section. We are going to take a section to process it for microscopic examination. So you take part of the necrotic area here, infarction, plus part of the surrounding kidney tissue. This will occur in the section. If you look at this section, you have again, look at this part, this microscopic section. This is a glomerulus. These are tubules, and you can identify very good that they are normal with a lot of nuclei and cytoplasm, and they are okay. So this is a normal kidney tissue. If you look at the other side, you have two parts like that. Look at this part. You have what? You have ghosts of tubules. You can see that these are tubules. You have just tubules like that. They are intensely eosinophilic as compared to the tubules on the normal side. This is the normal side, but you can't find any nuclei, no nuclei here inside the tubular epithelial cells. So you have the ghosts of your tubules without nuclei like that, and in between you have what? You have these inflammatory cells. So I have these dead part with dead cells lining the tubules, just ghosts of tubules with intact structural outlines. You can find that they are tubules. This is the structural outline preserved, but they have swollen eosinophilic cytoplasm and nuclear changes. Here we have karyolysis. You don't see any nuclei, and in between these dead tubules you have inflammatory cell. These are the inflammatory reaction that is present due to necrosis of these tubules. So in renal infarction here you can find the gross picture showing a pale-firm, swollen triangular area with apex towards the hilum and base under the capsule. Then it becomes yellow, opaque, and softer when inflammation takes place. Microscopically, we have maintaining or preservation of the structural outlines of the tubules. Okay, we have maintenance of the structural outlines, but the lining cells are swollen, intensely eosinophilic, and show nuclear changes, pycnosis, karyorrhexis, or karyolysis, and they are surrounded by inflammatory cells. So here we have the inflammation and the small dilated blood vessels that bring the inflammatory cells. So this is the gross and microscopic picture of renal infarction as an example of coagulative type of necrosis. Again, look at this picture and tell me what you can see here. Again, we have the kidney. Look at the picture here. Okay, look at this picture. What do we have here? Do we have normal tissue? Do we have necrotic tissue, or we have both? Okay, if you look at this is a normal part with nuclei in the cells lining the tubules and in the glomeruli. And in this part you have here necrotic tissue. Why necrotic? Look at the tubules, they are ghosts. Look at the glomeruli, they are ghosts. You don't have nuclei, and you have intensely eosinophilic cytoplasm, and in between you have this area of inflammation, inflammatory reaction going to the infarcted area. And so this is the necrotic and this is the normal tissue. Look at the picture below. What do we have here? Normal, necrosis, or both? Yes, you just have necrosis. You don't have any normal tissue in this view. All of them are ghosts of glomeruli, ghosts of tubules lined by these intensely eosinophilic cells with nuclear changes. They are ghosts. We have structural outlines preserved, but we have intense eosinophilic cytoplasm. We have lost nuclei, nuclear features, and we have inflammatory cells surrounding these necrotic tubules and glomeruli. So this is the coagulative necrosis occurring in infarction of the kidney. Second type of necrosis is called liquefactive necrosis, and it is the opposite of coagulative necrosis. Here we have predominant enzymatic digestion in the early stages, and this means that you have a lot of active or activated lysosomal enzymes early, and so they go and digest the components of the dead cell, and this dead cell will transform into liquefied tissue. It will lose all structural outline and it will transform into liquefied tissue. The enzymatic digestion is predominant. What is the source of this enzyme that causes enzymatic digestion? This can come from cell lysosomes and can come from outside the cell. So the enzymes that causes this digestion can come from the lysosomes or come from outside. Outside can be caused by neutrophils, polymorphonuclear leukocytes, in bacterial or fungal infections such as pyogenic abscess. pyogenic abscess اللي هو الخراج. وفي الخراج ده بيبقى عندي ايه؟ في الخراج ده بيبقى عندي بكتيريال او fungal infection، وبيجي عدد كبير جدا من النيوتروفيلز. A lot of neutrophils come in the pyogenic abscess, and these neutrophils will release a lot of enzymes, neutrophilic enzymes, okay, that causes what? These enzymes will digest the necrotic tissue, leading to formation of pus اللي هو liquefied pus، وده بيبقى موجود في الخراج. So the necrotic tissue will be liquefied and change into pus اللي هو الصديد, and this is liquefied. And so the enzymes occur causing liquefactive necrosis in abscesses are derived from neutrophils or polymorphonuclear leukocytes. Amoebic liver abscess is another example of liquefactive necrosis, but in this condition the enzymes come from a protozoan called Entamoeba histolytica. So this is a parasite protozoan called Entamoeba histolytica, and this Entamoeba histolytica has the ability to secrete a lot of lysosomal enzymes, okay, or digestive enzymes, they go and attach to other cells, kill them, and then they try liquefy these cells. And so the source of enzymes that cause liquefaction of the necrotic tissue comes from the amoeba this time. So in amoebic liver abscess, the source of the enzymes that causes the enzymatic digestion and liquefactive necrosis is the entamoeba histolytica itself. Lastly, we have brain cells after hypoxic injury. Remember that we said ischemic necrosis occurring in different organs is called infarction, and ischemic necrosis occurring in all solid organs caused coagulative type of necrosis except the brain. In the brain, if infarction occurs, I have enhanced autolysis and I have liquefactive necrosis instead of coagulative necrosis occurring in infarctions elsewhere. No one knows why. No one knows why, okay? But these are theories. So these are theories to explain this condition in the brain. Why the brain shows liquefactive type of necrosis in cases of infarction? Some says that there is high lipid content inside the brain and decreased glycolysis. We don't have enough glycogen, no glycogen inside the brain cells. So we don't have extensive glycolysis in the brain, and so you don't have decreased pH and denaturation. And at the same time, you have high lipid content that is amenable to autolysis, early autolysis. And so the high lipid content, decreased protein content, decreased glycolysis may cause this liquefactive type of necrosis and enhanced autolysis instead of excessive protein denaturation occurring in other organs. Also, there is a relative lack of extracellular structure proteins like collagen and reticulin in the brain. Of course, you don't have this collagen and so on. This will lead to rapid loss of the tissue when autolysis occurs, and this will result in formation of semi-liquid mass of the dead cells. So you don't have support. You don't have support to the dead cells. As in case of the kidney, you have the support of the connective tissue and so on. You don't have this support in the brain, and so when death of the cells occur and autolysis, they don't have any support, and so they just go and fall inside a semi-liquid mass, forming a cavity in the brain. So they form a cavity in the brain. Anyway, these are theories. You just have to know that the brain is the only solid organ in which infarction causes liquefactive type of necrosis and not coagulative as other organs. So liquefactive necrosis occurs due to predominant enzymatic digestion, can be seen in pyogenic abscess due to neutrophils, can be seen in amoebic liver abscess due to liquefaction by entamoeba histolytica, can be seen in ischemic necrosis of the brain or brain infarction due to enhanced autolysis. If you look at these are examples, okay, for liquefactive type of necrosis. Here we have lung, and this lung shows a pyogenic abscess, and this pyogenic abscess shows here a cavity in the lung, and this cavity contains necrotic tissue and pus. And so this is pyogenic abscess, and liquefaction occurred by the action of neutrophils. Look at this. This is a liver, and from our museum, this liver shows a single large cavity here with marked liquefied necrotic tissue leading to formation of this cavity, and this liquefaction occurred due to amoeba, and this is an amoebic liver abscess. So the liquefaction here occurred due to the action of entamoeba histolytica enzymes. Lastly, we have a brain tissue, and this brain shows what? Shows an area of necrosis here due to ischemia, case of brain infarction. And look at this brain infarction. It is soft and yellow and starting to have liquefaction. This liquefaction will complete, leading to formation of a totally semi-liquefied mass, forming a cavity inside the brain. So this is the ischemic necrosis, and the source of enzyme here is the what? Lysosomal enzyme. This is the autolysis. Auto means by myself. So I have lysosomal enzymes acting in the brain infarction, leading to liquefaction of the area of infarction. So these are examples of liquefactive necrosis: pyogenic abscess, amoebic liver abscess, and brain infarction. If you look at the microscopic level of brain infarction, for example, you have what? You don't have any architecture. You have complete loss of architecture due to liquefaction of the necrotic tissue. You have complete liquefaction of the necrotic tissue and formation of cystic space containing necrotic debris and macrophages. So this is the microscopic picture of the liquefactive necrosis occurring inside the brain. Inside the abscess, you are going to have inflammatory cells in addition. Okay, so there is complete loss of architecture, complete liquefaction of necrotic tissue, cystic spaces containing the necrotic debris, and macrophages are the features seen by the microscope in cases of liquefactive necrosis, especially in the brain infarction. Let's solve this match question. You have liquefactive necrosis and coagulative necrosis. Choose from B what suits A. Okay, liquefactive necrosis, we have what? Totally liquefied necrotic tissue goes with coagulative or liquefactive necrosis. Of course, liquefactive necrosis. Preservation of the cell structure outlines present in which liquefactive or coagulative necrosis? Yes, in coagulative necrosis. Amoebic liver abscess is an example of liquefactive, example of yes, coagulative type of necrosis. Predominant protein denaturation is present in which? Of course, coagulative type of necrosis. Predominant enzymatic digestion is present where? Of course, in enzymatic liquefactive type of necrosis. Fine? Very good. In summary, the ultrastructure changes of reversible cell injury include plasma membrane alterations as blebbing, mitochondrial swelling, densities, dilatation of the endoplasmic reticulum, detachment of ribosomes, and nuclear alteration in the form of chromatin clumping only. Two types of irreversible cell injury are necrosis and apoptosis. The ultrastructure changes of irreversible cell injury include cell membrane defects, mitochondrial swelling, lysosomal rupture, digested organelles, frequent myelin figures, nuclear changes in the form of pycnosis, karyorrhexis, and karyolysis. Types of necrosis include coagulative, liquefactive, caseous, fat fibrinoid, and gangrene. Thank you.